Morning, everyone. Thank you so much for joining us all here this morning for our first journal club for the year. I will hand over to Noleen, who will be hosting the journal club today, as our focus for this month is on antimicrobial use in aged care. So thank you, Noleen.
Thanks, Courtney. Isn't it lovely to be back at NCAS Journal Club? Hope you're all somewhere warm. It's freezing in Melbourne, 1 degree. But let's start. Just briefly, some housekeeping. If you could just keep your microphone on mute, of course. I think we're all practiced at that now. And there will be an opportunity for questions. So if you would like to type in the chat function, we'll get to those. We have 2 presentations today. These are updates on some exciting research grants. First is Ms. Eliza Watson, who will be talking about investigating and developing a national infection surveillance program for aged care. That'll be followed by Dr. Leslie Dowson, who will be talking about family experiences of Australian aged care workers in relation to infection prevention control measures during the COVID-19 pandemic. So if we start with Eliza, for those that don't know Eliza Watson is the project manager for the National Infection Surveillance Program for Aged Care, NISPAC project. Eliza completed a Master of Public Health at Monash University in 2018, specialising in antimicrobial stewardship, infectious diseases and climate change and health. She also has previous training in see, I'm too cold. Trying to thaw out. Prior to joining NISPAC, Eliza worked as a research assistant at the Alfred Monash University Department of Infectious Diseases. Thank you, Eliza.
Thanks, Noleen. So I'll just share my screen. Can you all see that? Okay. So yeah, as Noleen said, I'm the project officer for NISPAC, the National Infection Surveillance Program for Aged Care. And I'm just going to be talking to you a bit about that project today. So to give you a bit of background, as I'm sure you're all aware, there's been quite a lot of issues with infections in aged care over the past few years. But even prior to the pandemic, residents in residential aged care facilities have always been quite vulnerable to acquiring serious preventable infections, with almost a quarter of hospitalisations from residential aged care facilities being for infectious diseases. We know that infection surveillance is an important part of infection prevention and control activities for residential aged care. And there's currently 2 major existing surveillance programs in Australia for aged care. However, neither of these are nationally mandated. So the first is the VICNIS Infection Indicator Surveillance Program. This is run in all Victorian public aged care, and it looks at rates of various infections and also vaccination compliance for staff and residents. The other is the NCAS Aged Care National Antimicrobial Prescribing Survey. This is a voluntary program and it's available nationally to all residential aged care. So NISPAC is an NHMRC funded project. It's a 3-year staged mixed method study, and it's a collaboration between VICNIS, NCAS and the Registry of Senior Australians. The overarching goal of the project is to investigate, develop, implement and evaluate a national infection surveillance program for aged care. So basically what we're trying to do is develop a one-stop portal which has access to the VICNIS Infection Indicator Program and also to aged care NAPs. And in the process of doing that, we're also planning on updating the VICNIS Infection Indicator Program. So the goal of this is to streamline data entry for staff in aged care, and also having a national program will allow for standardised collection, collation and analysis of surveillance data. So this means that comparable facilities are able to benchmark themselves against one another. So just to go through the 3 stages briefly, the first stage is the investigation stage. So this is where we'll be looking at current surveillance activities, so those 2 programs that I mentioned, and understanding how they're currently performing. Stage 2 will involve updating the VICNIS infection indicator program and also developing the NISPAC portal. Finally, in stage 3, we'll be trialling NISPAC in a representative sample of residential aged care facilities. So today I'll be discussing mainly stage 1 with you and presenting some preliminary results from that, and also briefly going over the methods for stage 2. So our overarching aims for the project, firstly, are to develop a comprehensive and useful infection and antimicrobial use surveillance program, specifically for Australian residential aged care. The second is to ensure that this program is effective and efficient. And thirdly, to provide a dedicated and secure website that enables straightforward participation. One really key thing for us throughout the whole study is to ensure that what we're doing is really user-focused. So the users in this case are residential aged care staff who would be involved in entering data into the NISPAC portal. So the ways that we're doing this are that we have a consumer and community committee. So this has a couple of members of residential aged care staff as well as a resident representative. So we have regular meetings with them and keep them informed about the research methods and discuss various things with them to make sure that what we're doing aligns with what their expectations are. We also have various methods throughout the project, which include residential aged care staff. So this ensures that we're centering their opinions and listening to their needs. In stage 1, the main goal of this is to review and understand the current surveillance activities occurring in residential aged care in Australia from different perspectives. So to do this, we firstly sent out a survey. This was to residential aged care staff to understand more about their current use of infection surveillance and antimicrobial use surveillance. So we were asking questions about what surveillance activities they currently undertake, and then also specifically asking them about VICNIS and the aged care NAPs if they participate in those programs. Secondly, we conducted interviews with staff from NCAS and VICNIS. So this was to understand more about the performance of the aged care programs from the back end. And then finally, we're conducting a couple of scoping reviews about infections and antimicrobial use surveillance in aged care. So we've sent out the survey a couple of months ago. We were really pleased with our participation in this. We got 241 people clicking through to the survey. Approximately half of them completed the whole thing, while the rest partially completed it. Most of the respondents were from public aged care or not-for-profit, and there was an even spread of respondents from metro, regional and rural facilities. Most of the respondents were from Victoria, and they were mainly aged care IPC leads or IPC consultants. So we asked participants about what surveillance activities they're currently undertaking. This included asking them about a variety of different infections. It was really promising for us to see that most facilities, whether they're participating in the VICNIS infection indicator program or not, they are currently already including surveillance of a lot of these infections already, or they're interested in including it. So this is great for us because we can see that they already have the capacity or the interest to conduct this surveillance. We also asked staff about some general barriers that there might be to implementing or participating in a surveillance program. The key points that came up were that it's a considerable time commitment, that staff have competing priorities, that there's a lack of well-defined targeted surveillance plan, and that there's a lack of surveillance expertise and targeted education. So this is an important thing for us to delve into a bit further in stage 2 when we're developing the program. We also asked participants about their preferences for education. More than 70% of respondents said they wanted education into significant organisms, antimicrobial use, surveillance methodology, and interpretation of surveillance reports. They were mainly keen for webinars, but they're also interested in self-guided learning, online resources, and face-to-face training. So basically the message that we got from this, that they're interested in education on all topics and in all forms. So briefly, just to look at the respondents who participate in the VICNIS Infection Indicator Program, we're really pleased to see these promising results about this. So participants in these programs had overwhelmingly positive views of the program. 95% of respondents agreed that participating in the VICNIS Infection Indicator Program and the vaccination surveillance is useful for their aged care facility. Approximately 80% of respondents also agreed that participation in these programs has raised awareness of infections in their facilities. Most of the participants also agreed that data submission for the program is simple, but there were mixed opinions about the ease of identifying resident infections. So that's again something that we'll have to look into further in stage 2 when we're developing NISPAC. So we also conducted interviews. These were with staff from VICNIS and NCAS who are involved in the aged care programs. So we've just conducted some really preliminary analysis of this. So I'll just give a bit of a brief overview of some of the key opinions that came through in this. So all of the participants agreed that both of the NCAS and the VICNIS programs for aged care are really unique, and they're really good in the fact that they provide support and education modules for residential aged care staff. It was great to hear that both of the programs are quite simple to use from their end as well, and they're both very stable, so it's very rare for them to have any IT issues. Both of the programs can be easily and quickly updated, so this means that they can adapt to changing guidelines and definitions as needed. One thing that did come up a bit was that the programs haven't been recently updated, but as I said before, this is something that we'll be doing in NISPAC. There was also an awareness from these staff that residential aged care staff do often have limited time and competing priorities, which can make it difficult to participate in surveillance. So I'll now just briefly go over the methods for stage 2. So in this stage, this is where we'll be developing the NISPAC portal and also updating the VICNIS Infection Indicator Program. So stage 2 really builds on the results of stage 1. So now we have a bit more of an idea about the current surveillance activity programs and how they're functioning. We know what needs to be changed and what should continue on. So the VICNIS Infection Indicator Program for aged care was implemented in 2017. The current definitions that this is based on are, it's based on international definitions for infection surveillance. So these are widely accepted, but they haven't been validated for the Australian context. So in the development of NISPAC, this provides us the opportunity to revise the use of these definitions and assess what's appropriate for the Australian context and what we should be including for measurement in a national surveillance program. So to do this, we'll be conducting a Delphi technique where we'll be recruiting a panel of experts in various areas, including infectious diseases, epidemiology, and aged care. We'll be conducting a survey where we'll be hoping to gain a consensus about what definitions for infections should be used and what metrics we should be using to measure those. Next, we will be conducting some focus groups. This will be with staff from residential aged care who would be theoretically involved in NISPAC. So these focus groups will be there to discuss the barriers and enablers to implementing NISPAC. So obviously we touched on that in the survey, and this gives us an opportunity to delve deeper into that and to discuss some ways that we can support staff in using NISPAC. Finally, we'll be conducting some Think Aloud user testing. So this is where, again, residential aged care staff will be asked to test a prototype of the NISPAC portal. This Think Aloud user testing gives us real-time feedback from program users about the interface and usability of the program. So this means that when it comes time to actually trial the program in aged care facilities, that hopefully we will have addressed any issues with usability, and we can really focus on the implementation of the program. So we've conducted most of stage 1 now. So our next steps are to move on to stage 2 to develop the Delphi survey and recruit participants. And then finally develop the NISPAC portal. And then we'll move on to trialling the NISPAC portal in a representative sample of residential aged care facilities. Whoops. So a big thank you to all of the NISPAC investigators. And if you'd like to learn a bit more about the NISPAC study, you can also check out our website, which is listed there. It's nispac.site. Thank you.
Thank you, Eliza. That was certainly informative. We do have time for some questions, and I can see Linley has asked the first question. Hi, Eliza. Did you ask about what infection surveillance modules were most commonly used? Example, for respiratory or UTI? This is in the survey, obviously.
Yeah, so I think this would be closest to that one. So we asked about what surveillance modules are currently included. This doesn't list all of the ones that we asked about, but these were the key ones. So the ones that are most currently looked at the moment is COVID, followed by UTI.
Yeah. If I can jump in too and just say, for those that don't know, the VICNIS Infection Indicator Program monitors both significant organisms, so MRSA, VRE and C. difficile, alongside with vaccination compliance in aged care workers and residents. So aged care workers, influenza, residents, influenza, herpes zoster and pneumococcus. The Aged Care National Antimicrobial Prescribing Survey looks to monitor both antimicrobial use and infections on the survey day. That does include respiratory, skin and soft tissue, UTIs, eyes and other infections. They're based, those infections, the criteria are based on the McGeer definitions. We have a second question. Julius, it looks like you've made a start. You've said, hi, Eliza. I'm assuming you know Eliza. Is that a just hello?
Just a hello.
Yeah.
Oh, there you go.
Oh, no, here we go. We've got the second part of your question. Good on you. In our Aged Care ×5 campus, we do our monthly infection surveillance that includes MROs and keep a spreadsheet of all the infection in our aged care. Julius, can I just ask, are you one of the public residential aged care facilities in Victoria that you look to do that? Or do you look to collect, you're a public aged care in Victoria, I'm assuming. So all public residential aged care facilities in Victoria are required to participate in the VICNIS Infection Indicator Program. Any other questions? I'll keep checking. Eliza, if I can come back to you while we're waiting for other questions. It looks like you've answered most of them. But just the aged care IPC leads. You mentioned the consumer committee. Do we have representation of the leads on that committee? Because obviously this new role is going to be very important in regards to surveillance.
Yeah, sure. So we currently have one IPC lead. And we've just recruited another to start participating in that committee as well.
Great, thank you. I just want to emphasise, I'm going to come back just to questions come through, emphasise the aged care NAPS. So that's a point for those that don't know. All Australian residential aged care facilities are eligible to participate. That's an annual point prevalence survey. If you're interested to know more in detail, you can go to the naps.org.au website. It's currently underway. And as I said earlier, that looks to monitor the combination of antimicrobial use and infections on a singular survey day. From that was commenced back in 2015. And from that, we've learned a lot about what are consistent ongoing issues in regards to antimicrobial use and infections in our aged care homes across Australia. Any other questions? Oh, yes, sorry, Deborah, I can see yours. Is NISPAC going to replace one of the other current survey methods or be an extra survey? That's a really good question. Eliza, did you want to go first?
Yeah, sure. So what NISPAC is aiming to do is provide sort of a one-stop portal to access both of the current surveillance programs. So in the process of developing NISPAC, we'll also be looking at updating both of the current surveillance programs, but it won't be replacing them.
Yeah, I think that's really important to emphasise. That question's come to us previously. Again, it will not be replacing aged care NAPS or the VICNIS infection indicator program. It will be simply a portal to improved versions of those programs. There may be additional modules developed under the NISPAC umbrella, but yeah, certainly this is not going to be extra, an extra survey, or most importantly, not extra workload. We're not looking to increase workload. Kaz, you have a question.
It's not a question, but just a comment to the audience. I mean, one of the things that's happened is that, you know, Australia is actually ahead of the game in some respects. We are really one of the only countries in the world that's actually measuring antimicrobial correlative abuse. Sorry, my parrot, it always gets excited when I'm on Zooms. We're one of the only countries in the world that I know of, I think you could correct me, Noleen, that's actually measuring a quality of antimicrobial use at the granularity that we are doing with ACNAP. So we already know that there's many targets for action, but it's not good, I think, if we're doing this in a vacuum without understanding what's going on with our infections in our homes. So the aim of this is for our very, very stretched and busy providers to understand what's going on in a holistic way in their own organisation so that they can plan their programs. And in doing that, we already know it's been a wonderful experience with ACNAPs, particularly Noleen will attest to this, the opportunity to have been delivering, you know, passive education each year as we do it, and that more and more homes have come on board and have become very proficient in running it. But we do absolutely understand the time constraints and why we need to make it really useful. So that co-design piece and make it fit for purpose and usable regardless of the size of the aged care home, I think is a really important objective for us. I am going to ask you a question, Noleen, just out of interest, just before Leslie speaks. We've got a few minutes still. Do you think with COVID, we know that COVID has actually impacted stewardship and in many ways, but in terms of infection prevention, do you think that with COVID that the level of awareness and education around infection prevention in aged care has jumped up significantly? You know, the kind of practical application of it, or not?
I think there has been an increased awareness that the importance of infection prevention and control. I don't think necessarily in our teaching, our education, that we've taught our aged care staff how to risk assess, how to implement infection prevention control under different scenarios. So they're very practiced now at COVID-19, but what if I came in and said there's an outbreak of gastro? Would they know how to risk assess that and apply different infection prevention control practices? So I think it's good, just well, as far as these things go, post-pandemic, that there's been an increased awareness around the importance of infection prevention control in aged care, but I think we've still got a long way to go. And I think absolutely with our aged care IPC leads, we've got to recognise that, that you don't become an expert in a day. You know, it's going to take time. And so our expectations on them have to be realistic and fair. I'm sure others have thoughts, comments, so send them our way if you like. But I'm just a little bit mindful of the time now. I'll just finish to you, Eliza. You're contactable if anybody else has any further questions.
Yeah. So I think my contact details are on the website, but otherwise my email is just eliza.watson@mh.org.au.
Yeah, great, thanks. And I can just see one last attendee has made the point. My understanding is
Kaz is going to type.
there are still, we've got Kaz answering. That
Oh,
last comment.
no, I was just going to agree, of course. I think there's a perfect storm at the moment with many viruses, so things won't go away. And typically during winter, we often see an increase in antimicrobial prescribing as well. And then there's C. diff and all those things. So yes, we know.
Oh, I guess the Q&A, like only we see those questions. So a comment was made.
Oh, sorry.
The comment was, my understanding is that there's still COVID outbreaks in aged care plus gastro plus flu, and we are all saying yes, we
Very
agree
much so.
with that.
Very much.
Yeah.
Okay, thank you, Eliza. That was really informative. And Chris, yeah.
Oh,
Last
one more question from Christine, which is a great. We could maybe what we'll do after the Leslie's talk, we might come back to discussion if we can, because
We'll still have
obviously, yeah, it would be good at the end to understand how you can become involved in this, which we're obviously super keen for. So we might come back to the end. Yeah.
Okay, thanks, Eliza. Leslie, your turn. Leslie's in the room with us. So if I can just introduce Leslie. Dr. Leslie Dowson is a project manager with the Department of Infectious Diseases, University of Melbourne. In 2020, Leslie completed her PhD on optimising antimicrobial use in aged care homes with support from the National Centre for Antimicrobial Stewardship and the Centre for Medicine, Use and Safety, Monash University. He has many years of experience undertaking research studies with older Australians and a special interest in ethical issues and infectious diseases in aged care. Thank you, Leslie.
Sorry, Leslie, I'll just share screen. Sorry, everyone, just some technical delays, but now take it away, Leslie. Is that okay?
Yes. Thank you, everyone. I'm going to talk about some work that we've been doing on experiences of Australian aged care workers in relation to the infection prevention and control measures during the COVID-19 pandemic. I will try my best to do that. This isn't, sorry. Minor problem. Not advancing. There we go. Got it. That's all right. Sorry about that. This work has been funded through the Peter Doherty Institute for Infection and Immunity, particularly through the Agility Fund, which was donations from the public that was made through the website. As our researcher team, we're led by Lindley Lim Bickness, and everyone's location within the Doherty, where you might be able to find them if you come and visit us one day. This quote is actually very important to me, and very important, I think, to remember when talking about the experience of the aged care workers during the pandemic. I've been chased, I've been punched in the face, besides being spat on and scratched and nearly bitten. That's not your everyday sort of job. And this is from an enrolled nurse on working in an aged care home in Victoria. The aged care workforce has been described as being traumatized, by being extremely fragile at this point in time. And it's extremely important, if you're doing anything in aged care right now, that you recognize what it is that you are walking into. As Noleen said in the introduction, I did finish my PhD in optimizing antimicrobial stewardship with NCAS in December of 2019. And the very last thing I wrote in my thesis before references and appendices was that possible solutions and guidance for the future direction in this area, identifying and providing resources required for residents and families to feel confident about the care delivered in Australian aged care home. And I'll expand a little bit on that about why particularly it's important for family members to feel confident about the care that they're receiving. A little bit of context. I think everybody knows that residential aged care homes have been especially impacted by the COVID-19 pandemic. Victorian aged care homes were severely impacted in the winter of 2020. The epidemiological curve really took off from early July of that year and prior to widespread vaccinations. And just to give a rough number of how badly it was impacted, within 2 months, there were 381 linked deaths to aged cares in Victoria, which at the time was the bulk of the deaths in Australia. The Victorian Aged Care Response Centre was established by the Commonwealth on the 27th of July, 2020 as a partnership with the Victorian government in response to the threat. At the time, there were 60 aged care homes in Victoria had an outbreak. The response centre continues until September of 2022. Lynn Lee, who is our lead researcher, was very much involved in that response centre, as were a number of other research team. And our protocol was really written with the aim of capturing the Victorian residential aged care experience in the winter of 2020. However, because we had ethics delays, it meant that our data collection didn't start until February 14th of this year. And as a consequence, the current Omicron variant epidemic is also been captured in our data. Our questions and our methods were co-designed with 2 Victorian aged care personal care attendants. We have a demographic survey and a qualitative semi-structured interview over Zoom, which I've been doing. Those are transcript verbatim. And then the main outcome from this project will be a thematic analysis of understanding infection prevention and control behaviors amongst the staff. We currently have 15 interviews, which I will be presenting on, 10 registered nurses, 3 enrolled nurses, 1 PCA and 1 geriatrician. And I'm going to be talking about the role and the relationships between family and staff so far in our data. Our primary target was actually the PCAs, but they have been incredibly hard to recruit. And so it was opened up to anybody who was working in a residential aged care home in Victoria, staff or visiting professional from March to December 2020. We have metro, regional, and rural homes represented in our sample, as well as government operated, non-for-profit, and privately operated as well. The 2 biases that we do have in our sample is that all of our participants are currently still working in some capacity in aged care. Some of our participants have left where they were working in 2020 for reasons that were directly related to what happened there during the severe wave in 2020. However, they're all the stayers in the workforce. There are many people who have left the workforce since 2020. And we also have, I guess, a well-represented or heavy representation of the IPC lead roles, which Noleen talked about. They were established in November of 2020. And probably not surprising that people who are interested in IPC are the ones who are interested in participating in a research project on IPC. But overall, we have quite a well-educated, interested, engaged cohort of participants. So why am I talking about the family, and why am I talking about the family's involvement in both antimicrobial stewardship and infection control and prevention? Well, families are equal partnerships in the care that's provided in aged care, and in most cases, in many cases. They are extremely valuable to the workers of aged care homes and to the residents of aged care homes, particularly family members who come every day and who feed their loved ones, who help with personal care of their loved ones. And there have been, and I guess what I want to say is that when that relationship goes bad, it can go bad very quickly, and it's something that lingers within aged care homes as well. with regards to AMS in particular from my PhD, what we found was that in particular, family confidence in the care that residents are receiving are important in antimicrobial stewardship, particularly at the end of life, and also in instances where that you might want to try a resident off prophylaxis. The family, who are usually medical enduring powers of attorney, are not going to agree or not going to come on board unless they are actually confident in the care that's being provided. And I guess I also want to make the point that it's not all bad news. There's actually several really lovely stories, which I'll get into, and actually improved communications and improved relationships between the care workers and families. So these are two registered nurses who are just talking about the relationship with families. To give a bit of context, I wanted to be a midwife. I always wanted to work at that end of the spectrum, and I did my grad year involved working aged care, and I just fell in love with it. It's such a privilege to be part of the end of somebody's life, and help with the families as well. You just can't get there anywhere else. It's just a relationship with the resident and the families, and knowing who's who. They know that we are there and we can help them. It's the kind of trust, the rapport with them. It's really rewarding. I'll also say that I'm describing the narrative, so everything that I will say will be in the voices of our participants. And as I said, this is a story of improved communication. So because there hasn't been free-flowing all the time of family members in and out of the aged care homes during the pandemic, it's actually forced improvements in many cases. So I think probably the best thing of all this is our communication has improved exponentially. The minute we're going into lockdown, they get a text message straight away that we're in lockdown, and we get back to you and we follow up with an email, and we would email families at least weekly. And we're trying to reduce the COVID content of those emails. So we're starting to talk about wellness, a nicer email, that they're not just all our latest COVID guidelines and these are our latest visiting things. Our telecommunication between family and residents has improved hugely. That's been really, really good for the residents, residents in relative meetings. A lot of them Zoom into those meetings and they'll stay online and talk to their loved ones afterwards and everything. So those things have been really great. I suppose that's been extra for some of our staff as well, because a lot of our staff are also older and they're not that savvy around social media. So they've had to up their social media skills, because now the residents are starting to say, I want to get on Facebook, I want to FaceTime my family and all of that. So that's been a bit of a challenge as well. So I put that this is a government operated home because I'm actually not sure how much that has to do with the comparison to this story. That RN at that government operated home had a home of essentially less than 50 people that she was able to directly communicate with. Whereas this is sort of the exact opposite of that. This is an EN at a private group that has many, many homes around Australia. And what she said is, I think from a company perspective, it would have been good for the nurses on shift to have access to, say, an email, to be able to send out a text or a message to family members instead of having to ring our general manager and get that sort of thing sorted out. So she wanted exactly what the other nurse said that they had that was actually very successful. You know that if we had control, we would have actually pointed people in the right direction to government guidelines, because sometimes we're actually getting conflicting information. Yes, and families were coming and saying the government said this, and while that's not the information I have from my company, it can be very difficult. And then of course that puts extra pressure on our general managers and facility managers as well. I get all of these phone calls out of hours, and we, the nurses in the home, should be able to handle those, and we weren't able to. So to be clear, they weren't able to wasn't because they didn't have the skill to, it was because they weren't allowed to. And there are reasons why organizations such as that would want to tightly control what the message was. And those reasons are essentially many stories about what happened when families met unwanted infection prevention and control initiatives. We had emails to families that said, as much as possible, if you're feeling unwell, please don't visit, okay? So this nurse is even saying, okay, trying to get agreement. In April of 2020, we were checking temperatures of visitors. We received a complaint from family who contacted DHS and received a memo that said, the government is not telling you that they're not allowed to visit. I will try to limit, we're not discouraging them, it's hard. So no truer words have been spoken that it's hard. So they've asked for what they thought were reasonable limits on visitors. If you're sick, if you're unwell, please don't come. And that was seen as being discouraging of visits, and the family made a complaint. So that was in April of 2020. And really the story, unfortunately, is a number of tensions that have developed over the last 2.5 years. So the family members, I don't think, cope so well with it. They don't like wearing what they have to wear, and they always question, why do we have to? Some are good, but the majority don't love it. They're not. I don't know whether they can't see the need for it or think that they are immune to it. I'm not really sure. The complaints from families are the ones that are unvaccinated. They still want to come in. They still don't want to have to do the rats either. Before they come in, their approach is, why do I have to do this? I shouldn't have to do any of this. And we just talk about, we're trying to keep the residents safe or their loved ones safe, as well as other people in there. And they're the ones we get the most complaints from. I had a question yesterday from a research team. What they said, are there any examples of family members who have complained that the infection prevention and control measures weren't strict enough? And the short answer of that is no. We do have one story where a home took a vote amongst the residents to further restrict their family members from coming into the aged care home, but that seemed to have been a one-off incident. The complaints that we have where people believe that the infection prevention and control measures weren't strict enough are all in relation to staff action. So masking, whether or not, like, why are students still being permitted to come in, those sort of things, but not directly from family members. It's not to say that they didn't happen though. And unfortunately, after years of tension, we also have stories of what would be considered abuse. Good news is that they're sporadic stories of abuse. They're not the norm. So there was a family member refusing. He was abusive with that rat. He was just pouring out his anger and pouring at us. Don't be silly, show us the bodies, show us the bodies. I'm saying I'll call the police. So that was a story of a husband and a son of a resident who I guess believed in the conspiracy theories that there was no such thing as the pandemic. And the altercation escalated, to which point this enrolled nurse needed to call the police. It's important to remember that standalone aged care homes don't have security, such as big metropolitan health services. I witnessed somebody get very angry at the front of RMH, and quickly security came and was able to handle that. In aged care homes, that doesn't exist unless they are co-located on campus of a hospital. And so when things go very badly, the police are who they will call, unfortunately. And also, it's not a one-off incident, because the people where it goes badly, they're often, as I said, the medical enduring power of attorney, and those relationships have to continue even after such an incident. But I guess, why would families be fed up? Why would they be angry? Why would they be worried? Why would they have all these questions? And we talk a lot about the aged care system and what happens when the system breaks down. And so here's two stories. We get family members who travel, and of course situations can change literally within an hour. I had residents' families show up at the door, and 2 minutes ago we were accepting visitors, and then they're about to walk in the door, and I said, I'm sorry, I've just spoken to my manager. We're now in full COVID lockdown, and they've driven for 4 hours. So the family showed up after driving for 4 hours, and it was this enrolled nurse job to turn them away. And they had to drive home for 4 hours. And that's annoying. But I guess the next story is really what happened when essentially the system blows up. We just found out from a friend of a friend who said, oh, we have one of your residents here in another care facility. When we asked who, they gave us their name, and we were just very shocked. Wow, we thought it's been registered. The resident's death had been registered with the state. So we clarified it. She was recorded as dead, but she's not dead. She's living in another care facility. So I guess if you're the family member of that particular resident, how confident would you be in the care that was going to be provided to your loved one? And that's, I guess, where we are at this point in time. And as I said, if AMS requires resident and family members to feel confident in your care, I would suggest we've certainly gone a long way backwards in the last 2.5 years. And if you are going into an aged care home and you are attempting different interventions, you need to be very much across what has happened in the past 2.5 years. Just quick note, we are still looking for GPs and PCAs in particular. You have to be somebody who worked at least some days. It doesn't have to be the entire time in an aged care home between March and December 2020. And it's a survey and an interview over Zoom. The time commitment is about 60 minutes. And we have $50 supermarket vouchers for your time. And Hindi and English researchers are available. So if you are interested or you know somebody who might be interested, that is my email address. Thank you.
Thank you, Leslie. I'll just stop sharing and then we can see what's left on.
Great. Thank you, Leslie. Can I just respond and say, wow, how powerful qualitative research can be, and just how important, I think, to hear the voice of those that were actually working on the ground during this pandemic in these aged care homes. So the aged care workers, we've got a lot of commentary about what's happened in aged care from external persons, but it's so important to be hearing from those on the ground. We have a comment from Alana. Yes, this is a regular occurrence in my experience. Families want antibiotic therapy without clinical evidence of infection despite being provided education. They report the resident is improved generally on antibiotics. Would anyone else like to make a comment? I think, again, my response is just well done, Leslie, and to the team involved. For those that are requesting Leslie's email, yes, we'll respond to that and give you Leslie's email if you want to contact her. I might open up then, if you've got any questions for Eliza or Leslie. Thanks, Kaz.
It's more a question about, obviously there's this huge desire for any education about anything, which is not so surprising. I think if you ask many staff even in hospitals and other sectors, I think it's the same. People are time poor and they'd like to have focused education for their needs. How are we dealing with education for the non-RN staff? Because obviously the nursing profession have ways and means to, you know, and infection prevention societies and things. Is that open to these other staff of different languages? You know, where is the equity here when it's actually falling on their shoulders?
Yeah, good question. So I'll respond to it, and there's probably others online that may like to respond to. But I think during the pandemic, in my view, one of the biggest problems was across Australia. There were many groups with good intent that put up educational resources online. But where the problem lied is that the content wasn't always consistent. And so really, that caused a lot of confusion in the aged care homes. So going forward, I think different groups, if we could work collaboratively and bring the content so that it is consistent and very clear to whether it's PCA, whether it's a nurse and others, visitors to the aged care homes, that they can be confident in just one source of truth. Again, there's others online here today that probably have got views about that too, what they did and how they you know, worked through. It was almost like information overload throughout the pandemic. So, Kaz, to answer your question, there are resources out there, but it's, you know, to have the time to work through it all and what's best for your facility is primarily. Yes, Lindley, good point.
But no one can see that. So
yeah, so I'll just read it out loud because apparently no one can see it. The Aged Care Quality and Safety Commission has produced a quality improvement initiative that can be implemented by aged care nominated aged care champions around UTI management. It includes consumer shared decision-making resources when families request urine dipsticks or antibiotics for asymptomatic bacteria. So I think, thank you, Lindley. That's a really good resource out there that I would recommend strongly for those that haven't looked at it yet, to do so.
Sorry, Noleen, there were just two questions for Leslie. So if you want to come up and answer those. So one was from Alex. Are you looking to do a bigger study, for example, a larger group? Oh, so I think the question might be, are you looking to do focus groups? Alex, if you want to clarify, but I mean, going.
No. So part of our difficulty that we had with our ethics committee, it was actually quite interesting because focus groups and were actually approved by our the co-design team, and we had, I guess, a bit of a different slant on it. And in a very paternalistic manner, our ethics committee nixed all of that, said, nah, the group is too traumatized. The group is, we need to be careful about privacy issues. We need to be careful about all of these things. And so we ended up with a very sort of narrow lane, which a lot of it came from our ethics committee, surprisingly, being told, you know, what we can and cannot do, even after working with the actual workforce to design our study. So the answer is absolutely no focus groups, and it was all down to what happened with our ethics committee. We actually wanted to do focus groups initially.
Thanks, Leslie. The next one is from Marie. Love these stories. Is there any considerations to include the residents' stories?
The resident stories would be a different study. So the main focus of the study was actually to try to improve infection prevention and control activities from the point of view of the staff member. A lot of this other stuff, I don't want to say other stuff, but a lot of these narrative stories about relationships with families, about the difficulties, about the personal safety concerns weren't necessarily things that we thought we were going to get, but certainly speaking to the residents would be worthwhile, and speaking to families as well. So I am aware that we are speaking about families, and I'm certain that families felt legitimate in their concerns or feel legitimate in their concerns about what's happened, but that would be a different study.
Yeah. Thank you. Another one, can the aged care wards from tertiary hospitals participate in the research study?
No,
It's a different model of
it's
care.
a different model of care, unfortunately. Yes, I'd say unfortunately not. We do have, so rural facilities are often multi-purpose facilities that are sort of co-located. We do have representation from those facilities. But again, there was some movement throughout the pandemic that even in those facilities, the staff members were then solely assigned to the aged care unit. So it's a little bit different.
Yeah, no worries. Thank you. And then I guess then would aged care wards from tertiary hospitals be able to participate in Eliza's, like the next part of that study, or is that separate as well?
I'll let you answer that, Eliza.
Yeah, I think we're the same because it's a different setting as well that we wouldn't be able to.
Yep, no worries. And then just because we had to cut your question time short to move on to Leslie's talk, Christine asked earlier on for you, Eliza, how can they get involved in the focus groups?
Yeah, sure. So we haven't started recruiting yet, but if Christine wants to just send us through an email, she can head to our website. We've got a contact page on there which has all of our details. And Courtney, I don't know if maybe we can send through an email with the website link as well.
Yep, no worries. And this is being recorded, so this will be up on the NCAS website where people will be able to see the slides and the details. Yeah, we can definitely do something.
Lindley, you've been asked if you can share the link, please. For the aged care
for your commission.
UTI commission's resource.
I think I just popped it on. Can people see that? I just put the link in as an answer, but I'm not sure everyone can see that.
I don't know. When it said Q&A, I think it only goes to the person that asked the question. It's not quite clear how that works, but
We worked through all the questions. Do you think?
I think
It would have been good to have with all everyone on board. It would have been great to have some polls about some things.
oh yeah, Alana said she could see.
Yeah, so
if you've
great.
written it,
Yep.
yeah.
Is that the right one then, Lee?
I don't know how she can see it though.
Yeah.
Mm.
Lindley's put it online, so hopefully everyone can see
Yeah.
that.
What I might do
Yep.
is I'll copy it.
And we're going to copy that into the chat line. That's the link to the Aged Care Commission's UTI resource.
So in the last couple of minutes, I didn't get enough. I was just struggling to get on this morning. And so I did actually want to thank Courtney in particular. Some of you haven't met Courtney. So Courtney Rano is one of our NCAS PhDs and postdocs who's come back into NCAS and guidance, and she's taking over as the NAPS program manager. So it's fantastic to have her on board. She's a very accomplished researcher. Her own PhD was in the area of surgical prophylaxis. She did a wonderful mixed methods study, brilliant qualitative research, as well as analysis of the surgical NAPS data. And Courtney has kindly taken over from Arjun, who is over in Western Australia, undertaking his nursing degree and also helping, of course, as always. And so Courtney's kindly agreed to take over setting up the Journal Club, and thank you to Noleen as well for your work. We are keen to, I think there's been huge desire for the webinar to recommence, and you can see by the number of people on today that obviously it's a wonderful opportunity. We're going to purposefully run it a bit thematically to make sure we cover off key areas across animal and human health, and so we are prospectively working towards a schedule of what we're going to be covering off. Correct me, what's next month?
Next month is our vet colleagues presenting on their research. Yeah.
So very exciting work. And then the following month, sepsis, I'll be leading that one, given that the clinical care standards for sepsis have come out now. So thank you everyone for joining today. I think it's not too hard to find us or to contact us through NCAS or through any of these people directly. Thank you so much for joining this morning. You know, we're just so excited to see everyone in the numbers who have joined from all over Australia, I think. So thank you to Eliza and Leslie and to Noleen and Court. Thank you. And really, I can see it's been a fantastic session, lots of comments coming through. So I hope everyone has a great day.
Thanks,
Indeed.
Kaz. I just also wanted to plug in November, we will be also doing an Antibiotic Awareness Week, some seminars. Details will come out in the next month or so, but there will be sessions on aged care, as I know a lot of our participants from today were heavily interested in that work. So we will be doing more things in that space. It's not just this journal club. So keep an eye and ear out. Stay tuned. Yeah. Thanks,
Thank you,
everyone.
Bye-bye. Thank you.